Welcome, everyone. Thank you for joining us today for our webinar, Designing More Effective Nutrition Policy Impact or Policy Research for Impact. HER is thrilled today to be co-sponsoring this webinar with the Center for Health Inclusion Research and Practice based at Merrimack College. Before we get started, I'm going to just do a couple of quick logistics announcements. And first, please note that participants are automatically muted when joining. You can ask any technical or logistics questions for the host in the chat bar, but please make sure you submit questions for our panelists through the Q&A function, and we will get to these questions towards the end of the session, but we should have plenty of time for a great discussion. So with that, I want to introduce our moderator for today's webinar. Dr. Juliana Cohen is a professor of nutrition and the director of the Center for Health Inclusion Research and Practice at Merrimack College and an adjunct professor of nutrition at the Harvard T.H. Chan School of Public Health. Dr. Cohen is a nationally recognized expert on school nutrition policies and interventions with nearly 2 decades of experience collaborating with diverse school districts. Her research really centers on the identification, evaluation, and dissemination of effective school nutrition policies and initiatives to address diet-related disparities and reduce the risk of obesity among children. She has had many different grants, several from Healthy Eating Research as well, and I can't think of anyone better than Juliana to moderate today's webinar. So thank you so much for joining us, and I will hand it over to you at this point.
Great, thank you so much. First, thank you all for attending today's talk, Designing More Effective Nutrition Policy Research for Impact, and also a really big thank you to Healthy Eating Research for co-sponsoring this event with us. And I really think this topic is more important than ever, not only to inform strong evidence-based policies, but also to prevent evidence-based policies from being rolled back. It is such a pleasure to be introducing our incredible speakers, Dr. Punam Ohri-Vachaspati and Dr. Deanna Hoelscher. Dr. Punam Ohri-Vachaspati is a professor of nutrition at the College of Health Solutions at Arizona State University, where she also leads the ASU Food Policy and Environment Research Group. Her research examines social determinants of health in low-income and minority communities and studies the impact of federal, state, and local policies in shaping food and physical activity environments in school settings and in communities. Her work has been funded by multiple grants from the National Institutes of Health, the Robert Wood Johnson Foundation, and the U.S. Department of Agriculture, and she has over 100 peer-reviewed publications. Previously, she completed the Robert Wood Johnson Foundation Health Policy Fellowship, working in healthcare and nutrition issues in Senator Gillibrand's office, and more recently, she spent a sabbatical at the World Health Organization in Geneva, Switzerland, working with the Nutrition Division in the Action for Food Systems Unit. Additionally, we have Dr. Deanna Hoelscher, who is the Regional Dean of the UT Health School of Public Health in Austin, the John P. McGovern Professor of Health Promotion at the University of Texas, and Director of the Michael and Susan Dell Center for Healthy Living. Her research interest includes empowering children and their families to engage in healthier dietary and physical activity behaviors to prevent chronic disease, emphasizing addressing health disparities in diverse populations through behaviorally based and environmental interventions. Dr. Hoelscher has received multiple federal and foundation grants with over 200 peer-reviewed publications and numerous research, teaching, and mentoring awards. Dr. Hoelscher has held leadership positions in numerous scientific organizations, including as former president of the International Society of Behavioral Nutrition and Physical Activity, and more recently was a member of the 2025-2030 U.S. Dietary Guidelines Advisory Committee. It is with great pleasure that I'll first pass it over to Dr. Punam Ohri-Vachaspati.
Thank you, Juliana. Good morning and good afternoon to my colleagues on the East Coast. I'd like to thank Health Eating Research, the Chirp Lab, and Juliana Cohen for putting this panel together. And it's a true honor for me to be co-presenting with Deanna Hoelscher today. Next slide. So over the next 15 minutes or so, I'll share what I learned about the guideline development process during my last sabbatical at the WHO and how important it is to have a strong study design and conduct rigorous research so the findings from our work can be applied for developing recommendations that inform policy, which is what we are in this business for. I'll first describe the process of assessing the quality of evidence assessment and the grading process, and then share an example with you, ending with a couple of takeaways. Next slide. As a background, the WHO or the World Health Organization aims to improve health and well-being of people in the world, working with 194 member states and now 193 member states. This is done through three key functions. The first one is health leadership, and this is where WHO plays a convening role, bringing various stakeholders together. The second is development of global public goods for health, and this includes leveraging science to develop guidelines and monitoring and surveillance activities. And finally, WHO provides country support through technical assistance in member countries. So for this presentation, we'll be focusing on the role of WHO in guideline development process, and more specifically, use of evidence in the guideline development process. Next slide. So WHO guidelines contain recommendations to inform clinical practice and health policies, and are designed to help make informed decisions by practitioners and decision makers. The guideline development process at the WHO is managed by the Guidelines Review Committee, and the role of this committee is to ensure methodological rigor, transparent and evidence-based decision-making processes, to ensure those are followed for quality assurance. The ultimate goal is developing guidelines that meet highest international standards. As you can imagine, there are 194 or 193 member countries, and developing consensus through 6 regional offices is a big part of their work. Next slide. So this is a visual representation of what guideline development process looks like. It starts with the establishment of a panel of experts once WHO has made the decision to move forward with specific set of guidelines. The panel of experts decides on the PICO questions, which include population, intervention, comparison, and outcomes. They also decide on critical and important outcomes that need to be addressed, and as well as contribute to inclusion criteria for studies for systematic reviews. Following the initial meeting with the Guidelines Advisory Committee, a systematic review is commissioned that assesses the certainty of evidence using the grade methodology, which we'll get into in a minute. This information on quality of evidence is then used by the expert panel to develop recommendations. And additional contextual reviews are also conducted to provide considerations for implementation in member countries. Next slide. So let's look into the grade system, which grade stands for grading of recommendations, assessment, development, and evaluation. And this system is used to assess the certainty of evidence. So the aim is to assess how confident are we that the true effect of what we are going to propose lies close to the estimated effect, and to assess, previous slide still. Yeah, thanks. To support the recommendation. So the level of confidence can vary from high, where we have a lot of confidence in the evidence, to very low, where very little confidence in availability of evidence. And in initial assessment in the grade system, the randomized control trials start with a high level of confidence, whereas observational studies start with low. Next slide, please. So as I said, each study starts off with an initial assessment based on whether it's a randomized control trial or it is an observational study. And then these studies can be down or upgraded. So assessment criteria for downgrading include risk of bias. These can include bias in randomization processes, missing data, reporting biases, and other biases. Inconsistency in effect size across multiple studies, indirectness, that is, the study population or intervention or outcome may not be directly relevant for the PICO questions that are established, and imprecision, meaning there may be a wide confidence interval in the evidence, and then publication bias. So the certainty of evidence can also be upgraded, and that happens if the effect size is rather large, or there is significant dose response, or if there is enough evidence that the committee assesses that the confidence in the estimates of the coefficients would be stronger in the absence of some confounders. So if there are multiple studies that are addressing a particular question, the overall quality of evidence is based on the lowest quality of evidence for that critical outcome. So that affects the final assessment of the confidence is ascertained through the grade process. Next slide. So using the final level of certainty of evidence, recommendations are crafted. So grade emphasizes that recommendations should be based on best available evidence, and the strength reflects the level of confidence in that evidence. So both are important, availability of evidence and the level of confidence we have in that evidence. So the high certainty of evidence usually leads to stronger recommendations, and low certainty of evidence often leads to conditional or weak recommendations. Next slide. So in addition to systematic reviews, a contextual review is also conducted to provide contextual considerations for implementation to facilitate decision-making. These include considerations like values and preferences within the country context, equity, acceptability, and cost, and other contextual factors that may affect guideline implementation. Next slide. So there are some challenges of using grade methodology in public health, and these are recognized. WHO talks about these, but this is what that is currently in use. So the grade methodology was initially developed for use in setting clinical recommendations. And as a result, it gives higher weight to RCTs, and which are often difficult to implement in public health settings, especially in policy-based research. The choice of outcomes in public health settings is also different. We tend to have many more critical outcomes, and interventions in public health space also tend to be more complex. We often have interventions that are implemented in groups rather than single interventions. Next slide. Now, there are some tools available for assessing non-randomized interventions, such as the Robbins tool, but these are harder to implement, are not used as often, as it is considered that the risk of inflating the level of confidence is higher with their use. So currently, it's not extensively used within the WHO context. Next slide. So now that I've given a brief background about how the guideline development process happens, I'd like to share an example to illustrate how the process actually works. And for this example, I've chosen the development of guidelines on policy interventions that influence school food environments. These guidelines are under development right now. So for this, a panel of experts in the nutrition unit, this is referred to as the Nutrition Guidance Expert Advisory Committee, or NUGAG, decides on the PICO questions, criteria, critical and important outcomes to consider, and inclusion criteria. Next slide. A systematic review was then conducted to evaluate the certainty of evidence by Durao and colleagues from Cochrane, South Africa, that was published last year. Next slide. So I'm going to share some of the findings from this systematic review. So within this review, within the broad question, 5 interventions were selected by the NUGAG to investigate. And I'll focus on just one of them, which was the nutrition standards or rules that determine quality of food served and sold in and around schools. Next slide. The NUGAG also decided on critical outcomes, which included consumption of healthy and non-healthy food items and non-alcoholic beverages, nutrient intake, purchasing of food that is available in schools, and availability as critical outcomes, and anthropometry or weight outcomes were designated as important outcomes. Next slide. The types of studies that were included in the systematic review, the inclusion criteria was they had to be randomized control trial or interrupted time series with at least 3 time points before and after the intervention or the policy change, and prospective control studies. And as you can see, studies, interrupted time series with shorter intervals before and after were not considered, neither were repeated cross-sectional designs. Next slide. So then, following the grade methodology, the reviewers graded the evidence for nutrition standards for school foods as low on all critical outcomes. Even though the bias in most of the observational studies was low, the fact that most of them were observational studies at the get-go led to this final assessment. There was one randomized control trial, but it had serious risk of bias, so it was also graded as low. Now, these are the findings that will be used for by the NUGAG to make recommendations. Next slide. And as you recall, low certainty of evidence, as I mentioned earlier, low certainty of evidence can lead to conditional or weak recommendations, and high certainty of evidence leads to stronger recommendations, whereby WHO can say that WHO recommends doing X, Y, or Z, whereas a conditional or weak recommendations would be suggests. And what I want to highlight is that there is a long path between when WHO guidelines are released and when they are implemented by member countries. And it can be as long as 14 to 18 years. So the strength of recommendation has major implications for guideline adoption. A strong recommendation is much more likely to be adopted because, as you can imagine, all countries are working with resource constrained situations. So they need a stronger nudge kind of to act on these recommendations. And therefore, in order to have strong recommendations which encourage action, we need high certainty of evidence. So the chances of adoption are higher, and we get higher certainty of evidence, as you saw, with more rigorous designs, fewer bias, and so on. Next slide. So I want to leave you with two kind of takeaways or bottom lines from this recommendation. One is, as we design policy-focused research, we really need to be thinking in terms of, will this be included in a systematic review? Because unless it is included in a systematic review, the chances of making it to larger population recommendations are rather slim. We need to think about how will it be graded? How will the design impact the certainty of evidence emerging from the research we are conducting? So these are on the design side. But I think we, as nutrition policy researchers, we also need to become advocates for this field. And the idea is that we need to develop and implement new methodologies for grading policy-focused research, because RCTs are really not an option in many of the situations and many of the studies that we conduct. And WHO is working towards that, but right now that's not what is used for grading evidence for policymaking processes. Next slide. And here are some resources I want to leave you with: the WHO Handbook on Guidelines Development and the US Advisory Committee on Immunization Practices, which also uses the grade methodology. It's an interesting thing to consider, to be actually thinking about where we want our research to be leading and be used in nutrition policy. And with that, I'll pass it on to Deanna to share her experience on the Dietary Advisory Committee, Dietary Guidelines for Americans Advisory Committee. So thank you.
Thank you, Punam. And I think what I'm going to present really flows nicely from what Punam has already presented. And I'd like to also thank Healthy Eating Research and CHIRP and Juliana Cohen for arranging this webinar. So next slide. So what I'm going to talk about today is very briefly, like in one slide, talk about a little bit about the dietary guidelines and then the committee. Then I'll talk a little bit about our development process and reviews, specifically focusing on the systematic reviews. So you'll see a lot of similar themes that you've seen in Punam's presentation. And then I'll address some research gaps and leave you with some conclusions. So next slide. So I just wanted to reiterate how the committee's scientific report differs from the dietary guidelines. So our report looks at the current state of nutritional sciences. And so this report that we develop is given to the departments, HHS and USDA, and then they will develop the guidelines based on information from this report, but also information from other federal reports. So just to give you a reminder of what part this Dietary Guidelines Advisory Committee report plays. One other thing, just to let you know, is they convened us in February of 2023, and then we finished the report in December of 2024. So it's a pretty short time period for development of the systematic reviews and other analyses that we did. So next slide. So I just wanted to give a shout out to the members of the Dietary Guidelines Advisory Committee. Sarah Booth was our chair and Angela Odoms-Young was our vice chair, and we just had an excellent committee. Next slide. For all of the systematic reviews, we had a team working behind the scenes, and so I just wanted to acknowledge the Health and Human Services and USDA support staff, specifically Janet De Jesus and Eve Studi, who kind of directed the entire process. So next slide. So just a little bit about the reviews that we did for the scientific evidence. So we did independent reviews of the current scientific evidence. We used a health equity lens in our processes. So one of the reasons we did that is we know that the prevalence of obesity and other chronic diseases that they are still prevalent in the US, and we know that certain populations are disproportionately affected. So that was one of the reasons we adopted the health equity lens. We also realize that there are a lot of other factors that influence dietary intake, such as social determinants of health or non-medical drivers of health, such as food availability, transportation, economic factors. And for that reason, we supported health equity. So as part of what we did, we developed protocols, we reviewed and synthesized the evidence, and then we presented the findings. We considered all of the public comments. We also published all of the protocols prior to doing the systematic review. So the public had a chance to provide feedback on those. Next slide. So we used 3 approaches to examine the evidence. So one was data analysis, where we looked at what is the state of dietary intake in the US, what is the state of chronic disease prevalence. The second group was the systematic reviews, and I'll talk more about that. And then food pattern modeling, where we did modeling what happens when you change different amounts of foods. A very interesting technique. Next slide. So when you look at our work across the 3 approaches, the report integrates all 3. So as you can see with the systematic reviews, we completed 28 systematic review questions and then 1 evidence scan. So we reviewed almost 2,000 new references. So that really builds on what prior committees did. The questions were selected by the departments prior to us being appointed. So we did have some prioritization of the questions, but we were given many of the questions that we ended up doing with systematic reviews. The other thing to point out is we had a short time period, so we weren't able to necessarily get around to all of the reviews. So some didn't have enough literature. So we weren't able to pursue that further. So next slide. So kind of building on what Punam said is there were a lot of questions from nutrition researchers about why we didn't include certain studies. So I'd like to kind of show what we did in the systematic review that might have caused a study to be in or out of the systematic review. So next slide. As you all know, when you put together a systematic review, you set up an analytic framework. And so, as I mentioned previously, the framework is set up before any work begins on the systematic review. So this particular framework was the relationship between dietary patterns and varying amounts of ultra-processed food consumed. And so that's the intervention exposure, and then growth, body composition, and risk of obesity, which was the outcome. So this is our PICO table. And so a few things to note here is, one, with the population, we took a developmental approach. So we looked at age categories because we know that dietary requirements differ by age categories, and we also know that behaviors, capacities differ by age and developmental level. So in this case, the intervention, exposure, and comparator was consumption of a dietary pattern with ultra-processed foods compared to a dietary pattern without ultra-processed foods. So we did not rely strictly on NOVA because that would have limited what's out there, and there really isn't consensus. There's several definitions right now that talk about what an ultra-processed food is. So we either looked at those two or we looked at different adherences to a diet. We looked at both RCTs and we looked at prospective cohort studies too. So as Punam said, a lot of our data, especially when you're looking at long-term chronic disease or health outcomes, you need prospective cohort studies that are well designed and well done. The outcomes and key confounders differed by population. So that's another important factor to consider. So the next slide shows our conclusion statement and grade for this particular question for adults. So I didn't show the other age levels. But basically, this the body of evidence you can see there was 16 articles, 1 RCT, 15 articles that were from prospective cohort studies. The grade for this was limited. So the grading that we use is the USDA Nutrition Evidence Systematic Review. And so there have been several methodological papers published on this on the systematic review procedure. And so as you can see there, the studies were, as a body, were graded for consistency, precision, risk of bias, directness, and generalizability. So Punam mentioned the grading elements. So these are similar to what she said. We did use the Robin, the risk of bias in non-randomized studies of exposure, and then the Robin for risk of bias in non-randomized studies of interventions. So we did use that as to evaluate risk of bias. So in terms of the grading system is a little different than what we saw previously. So the grades ranged from strong to moderate to limited to grade not assignable. So strong meant that it is unlikely that if new evidence emerges that the conclusions would change. So the next slide. So just some information about research design issues for the systematic reviews. So one is we looked at developmental levels. So in some studies, you didn't have age categories, or it could be that they included both adults and children and didn't stratify. So sometimes that was an issue with studies. The intervention, exposure, and comparator definition, those were often difficult to assess. So for example, if someone did not state that they used a specific dietary pattern or really any dietary pattern that you could tell from the methods or the abstracts, it often didn't make it into the systematic review. So the dietary guidelines, just to remind you, is we're looking at usual patterns of eating. So really looking at what the pattern is rather than individual foods was important in these systematic reviews. Outcome definitions could be problematic. So I'll talk a little bit about breakfast consumption later, but one of the ones that was especially problematic for us was gestational weight gain. So for example, in pregnancy, you don't always have a standard for when they started and when they ended. So we looked at gestational weight gain. Key confounders were not always included. For the dietary guidelines, many of the systematic reviews, not all, used a 12-week time period. And so it depended on what the outcome was. So for example, for growth, body composition, and risk of obesity, we thought that the intervention needed to be at least 12 weeks to see kind of more sustained changes rather than a 2-week intervention where you might have rapid weight loss, but it wouldn't necessarily be maintained over time. We know that a lot of diets can cause that. We also looked at the generalizability to U.S. populations, and especially in terms of diversity. We didn't include uncontrolled trials, and as I mentioned before, sometimes there just wasn't enough literature for the review when we did a scan. Next slide. So I'm going to talk a little bit about research gaps that were identified. And so some of these are where nutrition research needs to go. So the next slide kind of shows the main categories. So one is future directions, where we thought, the committee thought the dietary guidelines process needs to go. The second is on strengthening the nutrition surveillance system. So that's not something we can do, but I think that some of that methodology is important for us to pay attention to. And then finally, some other methodological considerations. So the next slide, one of the things we looked at is we wanted to look at the impact of culturally tailoring diets and tailoring an intervention and then outcomes. And what we found is this was really difficult to do. So one of the big issues was there isn't really a good classification system like Consort or Prisma that really kind of takes into account all the things you need to do to culturally adapt an intervention. So it was very mixed. We also thought that future research really needs to communicate plans for community involvement and sustainability. So that didn't always happen. Addressing social determinants of health is important. One of the things we found is we ended up going back to race ethnicity because there weren't standards for socioeconomic position. Tailoring was important, and then diversifying search terms, because it was often difficult to find studies that had done cultural adaptations. Next slide. One of the ways we really think, we did some of this, but we really think that the dietary guidelines needs to look at behavioral science and implementation research. So some of that includes use of behavioral theories, describing behavioral strategies used, using some of the behavioral taxonomies that are currently proposed, and then systematic reviews of effective strategies for dietary change. So we really thought that was a good direction. The other thing we identified in this category happened to be evidence-based policy systems and environment change. So which strategies work for different groups, and groups that were especially lacking in data were young children, adolescents, and then pregnant and lactating women. Next slide. We also thought that communication strategies were very important. We feel like messages about healthy eating don't always reach the population of interest. So we need to communicate guidance that resonates with different audiences. There should be better use of social media and interactive technology that can be used to deliver complex nutrition messages, and then just addressing health literacy and numeracy. And in terms of that, for future DGAC committees, we really recommended members with this expertise. Next slide. So for the surveillance system, some of what we propose is just continuing to support NHANES as a great source of data and to look across time. And so part of that is increasing sample size and oversampling for different populations. It really would be nice to include other populations of interest in NHANES. We know that would incur costs, but we think that those data are invaluable. We also recommend to incorporate or expand instruments that capture other non-medical drivers of health or factors that influence dietary intake. So kind of expanding that. Next slide. The other thing that needs to be addressed is databases, food databases. So we know, although we have a rich database, it doesn't always keep up with what's happening in the marketplace. And especially when you're looking at non-nutritive food additives or things like phytonutrients, those need to be included. And then a couple of other recommendations were human milk composition, and then to continue to update the DRIs. Next slide. A few other methodological considerations is one, a lot of the observational studies that we looked at for the systematic reviews were conducted outside of the United States. So it would be nice to have those cohorts conducted in the United States with more diverse populations. We do have several very good cohorts that have been going for years, but really diversifying the population there. We also need to develop consistent nomenclature and components for dietary patterns so that people include them in their research, so that they'll get caught and used in these systematic reviews. And then develop evidence-based and consistent nomenclature for food groups and subgroups. Sometimes people would say these were red and orange fruits and vegetables. And so the categories didn't always match. And so that made it difficult. So next slide. So just a few other research needs is one is consistency and exposures. So when we talk about mealtime, you need to define really clearly what is breakfast. Is it the first meal of the day? And then how do you assess breakfast? Is it one day? Is it 5 out of 7 days a week? It really makes it hard to do a systematic review when there's so many variations on a theme. Consistency in age groups across lifespans. So what is it 6 to 11 that you look at? Is it 6 to 8? So a lot of times these might be like 7 to 13 which cross children and adolescents. Ultra-processed food was a big theme, and consistency and exposure. How do we define that? And then looking at it across other health outcomes and populations. And then population research needs. And here I'd like to highlight, especially adolescents, which had are most in need of dietary intervention. So finally, last slide, conclusions. Despite many studies, we have several more important research questions that need to be answered to inform the next dietary guidelines. We know that despite advancing research, that dietary quality, the healthy eating research, the healthy eating index over time has remained relatively stable. So we really need to look at other strategies to address uptake and sustainability of healthy diets. We need representation of diverse population groups. That really was a lack we saw. And then new methodologies and expanded databases that better inform what people are eating. And with that, I'd like to point you to the scientific report of the 2025 Dietary Guidelines Advisory Committee, and thank you.
Thank you both so much. Those were absolutely fantastic talks. I really, really appreciate that level of detail and just how informative this was. And so would like to remind everyone, if you have questions, you can post it in that Q&A box at the bottom. And Deanna, one question I have for you, kind of leading off of your presentation, is around kind of some recommendations around some questions were recommended to actually be deprioritized in the next Dietary Guidelines Committee. And I was wondering if you could give us a few examples and explain why they were deprioritized.
Yes. So one example is the relationship between dietary patterns and cardiovascular disease, because for several cycles of the DGACs, the evidence has remained strong. We evaluated it with a health equity lens, so we really looked at diverse populations. It remained strong. So mind you, this is for adults, so the evidence is not at the same level for adolescents and children. So those are populations, and pregnant and lactating women. So those are populations that do need more research. But maybe for adults, it's not that we don't want to do any work in that area, but some of these others we need to elevate and do more work in those areas.
Thank you so much. And Punam, I was wondering if you could kind of talk a little bit more about kind of the World Health Organization with the grade method, which obviously really elevates RCTs. And as you noted, so many of our studies, especially policy research, often can't be RCTs. So I was wondering if you could talk a little bit more about what can both be done with this system, as well as if you have recommendations for those of us who are researchers and what we can be doing to kind of elevate our non-randomized research.
Yeah, so while they're using the grade methodology, this discussion goes on a lot. I talked to many people in different units about this issue of using grade for policy focused research because they make policy relevant recommendations. So this realization is there. And I think the committees, the expert groups that make the recommendations like NUGAG can take that into consideration, that this is the best evidence available. But in order for it to be best evidence, think about the inclusion criteria that I specified, right? There was RCTs, but then for interrupted time series designs, they want, a good amount of time before and after the intervention or the policy level shifts, minimizing bias in our studies, and using one of the things that becomes challenging is we all use different methods, we use different outcomes, we use different study designs. So putting it all together becomes challenging in a systematic review. I'll give you some examples from this systematic review, which really bothered me. For example, to look at the weight outcomes in children as a result of school meal guidelines, the systematic review includes only one study with 3 subsections conducted in Chile in 2008 on 2 to 5-year-olds. So because they were looking at it, these were their inclusion criteria, there's so much else, other research that's available, but those were not included. So I think to me, it becomes, look at the systematic reviews, look at the inclusion criteria. How can we elevate? How can we strengthen our design? I don't think we can do RCTs in our space, and that realization is there. But I think using some common measures, common tools, so that data can be synthesized more effectively is a good way to think about it.
Great. Thank you so much. And Deanna, another question for you. And I think it's fantastic and so important that the Dietary Guidelines Committee really looked at this research from this kind of health equity lens. And now there are potential constraints around even using the word equity in the current environment. And so one question that we got is, kind of one, is there anything that kind of the nutrition community can be doing, both to ensure that kind of critical elements of the scientific report are implemented as part of those the actual dietary guidelines, and any additional kind of suggestions, things like that for us as researchers, for the research that we're doing that may be equity focused moving forward to also ensure that it's included in future recommendations?
Yes, I think several things. One is, I think, looking at equity in terms of different parameters. So in terms of maybe regional differences, where you can often have populations are concentrated in different regions. So that can be important. Rural versus urban, for example, is another kind of disparity type topic that you could look at. I think where food is concerned, really emphasizing the cultural roots of some of the food ways. The cultural adaptation with several of the populations we looked at. I had a student the other day that said we were doing 24-hour recalls and she couldn't find the food she was eating, in the database. So I think it's really important for us to pay attention to that cultural aspect. And I think that that's a way that we can bring it in. And now that cultural foods have kind of expanded, it ends up benefiting everyone at the end. So I think we need to make that case. And still continue to do the good work that we're doing.
Great, thank you. And another question that I have for both of you, another question that we got was really around funding. And so part of the question was thinking about, is part of the reason we kind of have a lack of evidence in part because of, lack of funding. And I was also thinking about in the current kind of challenging funding environment that we have right now, one question I had for both of you is actually, is the funding source considered when thinking about the kind of risk advice bias, such as was it funded by industry, for example? And if you have any other just kind of recommendations, especially for those who might be more junior researchers, students, et cetera, around thinking about funds to be able to create, to produce high quality work.
I think so. So WHO puts a lot of emphasis on how they bring people together, how they bring evidence together, and minimizing the influence of corporate sector into all of that. So I think that is a key element for assessment of, whether it is the bias or bringing the stakeholders together, bringing the expert panel together, who's been funded by who. So it's not just the study where the study is funded, but when they bring people together, they look at every individual's association with industry partners with a very fine tooth comb. So that is a big issue that I observed at WHO.
When we did our systematic reviews, I can say that it wasn't a large percent that were funded by industry. Those tended to be, and I'm generalizing here, so in certain areas that might not be the case, but they tended to be smaller, shorter term duration. So one of the things that we were really interested in were better prospective cohort studies. And I know that there are certain scientists that aren't enamored with them, let's just say, but there's some newer modeling techniques. I think that there's some newer methodology that we can include. I know that NIH was not particularly, that's not a high priority on a lot of the NIH side. But there are other organizations, I am thinking like American Heart or, so groups like that might have a disease focus that would be interested in cohorts. The other thing I think is, the other thing that just to suggest is there's a lot of good data out there right now. And so there's a move underway with NIH to get the most use out of those data. So there's a lot of data sets that you can look at and ask some of these questions. So that's another way I think that researchers can move their work forward. I think the last thing I would say is maybe look for local foundations in your state or region that might be more interested, especially if you're looking at populations close to home. They often have a vested interest in the community, and so those can be effective ways to fund. And we've also found funding through groups like banks and, kind of community benefits. So don't be afraid to look at other sources.
Those are fantastic suggestions. Thank you. And my next question is again for both of you. And this is really thinking about it from a policy lens, because we know that oftentimes policymakers have to make decisions quickly. And I was really hoping to get both of your thoughts on how we as researchers can kind of overcome some of these differences if we want to be relevant in the policy area.
I think one of the things with researchers is we tend not to want to say something until we're absolutely certain. And I think for policymakers, they have to make a decision and they don't have a lot of time. So all of us really have a lot of knowledge. We've got these systematic reviews, guidelines, and just our own experiences. So I think looking at that and making the best decision that we can in terms of framing our research. I think the other thing that we don't do very well is really get out into the public sphere with our research and what we're doing and what does it mean. So we really need to be proactive in interfacing with the public, whether it's social media or other aspects.
I think those are great points, Deanna. I think the one thing that I'd like to add is getting more involved with decision makers and advocates as we are thinking about our research, right? Co-creating research questions with advocates and policymakers so that what we are working on is meaningful for them. Because oftentimes we wait after we've done our research and take it to the decision maker and say, hey, this is what I've done, I'd like you to do X, Y, or Z. But I think if we bring them in at the ground level, work with the research questions with them, I've found it to be so impactful in our state to work with advocates and decision makers. And I'd like to just pitch one idea which I've been pushing is for researchers and advocates to work really closely together so that we can speak in one voice to decision makers. Because as much as we want to be advocates, our training is not in advocacy. So if we can funnel our findings to advocates so that what they are advocating is evidence-based, and then we can add our voice in the platforms, whether it is you're walking the hallways of your local legislatures or what have you. Advocates have the pulse of what's happening, right? Which is the right legislature to go to and so on. So I think if we build those connections strong and build them as we are thinking about our studies, as we are thinking about writing grants and so on, I think the uptake or adoption of what we produce is likely to be much higher.
Thank you. Those are really great suggestions. And then another question that I have is around, and this is for both of you again, especially the first, Punam, thinking about what is the role of meta-analyses when we think about the grading system, but also for both Punam and Deanna, I'm curious about how kind of other modeling techniques like microsimulation models, which our own research group has used, where does that kind of lie in terms of how this is viewed and included in these type of recommendations as well?
So meta-analysis become part of the grading system. Like if there's evidence from certain number of studies, the part of the systematic review would be to run meta-analysis. But what is oftentimes challenging in these, for some of these policy-centered studies is that we use very many different designs, or the outcomes may be different, or the populations may be different. So it becomes challenging to put the designs together. So for example, in this particular review that I was talking about, they used a vote counting method, right? Evidence direction to see which way were the studies leaning. So instead of running a meta-analysis because they couldn't, because of certain limitations. So I think it has a place in it, but I think if our studies are stronger designed, and I'd go back to Deanna's point that she was making, if our studies are easier to find, using the right terminology as we are putting keyword searches or mesh terms or what have you, so that they're more likely to be included, I think that's increases the likelihood of including them in the systematic reviews. I didn't hear about the approaches related to modeling methodology, use of modeling methodology at WHO. But what I did hear and see quite a bit of was these contextual reviews, which were really meaningful and often made weaker recommendations more powerful because they could contextualize them. So for example, in school food space, it's very seldom that you have just one intervention, right? It's often done as a group of recommendations. And these contextual reviews then bring that forward, and that really helps the decision maker to see, even if it is a weaker recommendation, this is the context in which it can be stronger, if you combine it with other things and so on. So I think to me, that was really interesting because I was really disheartened by seeing the lower levels of evidence coming from policy research. But I think those contextual reviews were very meaningful.
For the Dietary Guidelines Advisory Committee, we had a couple of systematic reviews that we also did meta-analyses for. So that was very nice because you were able to pull in data from both of those techniques. I think in terms of modeling, we did use some modeling in our systematic review question about saturated fat. So especially with some of the substitution modeling that was based on the real data, and that was very informative. I just personally, we're doing some work with physical activity, and we just completed a study, and it kind of matches some modeling studies that others have done in terms of the time for changes to occur, which is making me more of a believer in some of those, kind of adding to that. But I think you have to be real careful about what your assumptions are and what it's based on. So you can't get sloppy about that because, garbage in equals garbage out. So you have to be really careful about setting those up appropriately.
Great. Thank you so much. I know that we're at time now, so I would just like to once again say thank you so much, both Deanna and to Punam. This was just absolutely fantastic talks. And also, again, would like to sincerely thank Healthy Eating Research as well for co-sponsoring this with our Center for Health Inclusion Research and Practice. Thank you all so much for attending.
Yes, thank you. The recording will be made available in the coming days. We very much appreciate your interest and hope you will share the webinar recording with your networks. Have a wonderful afternoon, everyone.